Hello, and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and long-term contributor to infectious diseases and immunizations topics at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much everything else in between and surrounding. This is the second week of 2024. Happy New Year, everyone, and the week of January 8th. And it's been a couple weeks since we last spoke. Since that last podcast, of course, we continue to see plenty of cases of RSV, increasing numbers of influenza, especially A. About 75% of the flu cases out there are influenza A, and specifically influenza A H3N2. The former H1N1, dear friend from the 2009 pandemic, is sort of a distant second in terms of numbers of cases out there. And of course, we also see a I won't even use the word surge, a mini increase, how about that, in COVID-19 cases. Many mainly because we've never really had a complete absence of COVID-19 in pediatric patients. Even since the last surge with the last Omicron increase, we've continued to have sporadic cases of especially upper respiratory tract infections with SARS-CoV-2 and continued fairly severe croup. So again, that significant laryngotracheal bronchitis caused by SARS-CoV-2. So our questions today are sort of a nice, wonderful smattering of things, especially having to do with COVID-19 and also a couple about other stuff. So we'll launch right into it. The first one is a important one. Well, they're all important. What am I talking about? The first one I think is important to us even today as we think about how to navigate. And it's basically asking about mask mandates in healthcare settings. So the questioner asks, read an article that some healthcare facilities have reinstated mask mandates. And with COVID-19 cases increasing currently, would I recommend healthcare staff who interact directly with patients to start wearing masks again? So to start off with the facts of the matter, yes, there are 4 states in which hospitals, not all hospitals in the states, but in which hospitals have reinstated mask mandates. In those 4 states currently, states of New York, California, Illinois, and Massachusetts. Now again, that this is a hospital by hospital decision process. My hospital has not chosen to do that, and I'm not even aware that it's being discussed. And so you have to think about the benefit of mask mandates in terms of wearing them all the time, which is typically what it means, like enter the hospital space or the clinic space for those of us in the ambulatory world and immediately put on the mask versus the more typical masking when going into a patient's room or masking when going into a respiratory illness patient's room. In the early days when mask mandates were ubiquitous, it was unclear what the transmission patterns of SARS-CoV-2 exactly were. And if you recall, there was a significant back and forthing about whether it was airborne, meaning microparticles, which would last or persist in long term in the air spaces, or the more typical respiratory transmission, which is larger droplet, similar to what we're used to with other respiratory viruses like influenza, adenovirus, etc., and so forth. And as it turns out, it is unfortunately a combination of both. But those patients with the airborne transmission are likely to be more severely ill, to have far more aggressive sort of hyperinflammatory respiratory disease of the lower respiratory tract. Given that in pediatrics at least, and to a large extent the adult world as well, COVID-19 remains an upper respiratory tract disease, it is less likely to be transmitted with persistent airborne particles and far more likely to be the typical respiratory droplets, the ones which will project out maybe 3 meters or 6 feet-ish, depending on whether you're metric or English. And so therefore, masking going into a known respiratory patient's room is the far more expedient and appropriate. So I guess what I'm trying to say is there's, at this point, given numbers of COVID-19 and expected transmission of SARS-CoV-2, there does not appear to be any additional benefit for masking 24/7 or however long one is in the clinical space. And this actually holds true as we settle into COVID-19 becoming a seasonal epidemic, just like influenza, just like RSV, etc., and so forth. And in those cases, it is found to be appropriate and relatively protective to us as healthcare workers to mask only in a need-based situation, meaning about to see a patient who has fever, respiratory symptoms, or who may have any of those, then of course, as we would with anybody else during the flu season, we would throw on the mask and be appropriate and of course wash our hands versus the mask all the time. So not that this podcast is intended to be a recommendation. I would certainly encourage you to make your own risk-based assessment of risk in your local practice area, and especially if you are in parts of the country that are seeing a significant burden of COVID-19. But I don't feel at this point that universal masking or mask mandates have scientific merit or benefit at this time. There, how's that? Went on the line, said it. You do what you got to do. But do keep in mind that if we are going to wear masks, they need to be worn properly, right? And especially need to be followed with pre and post hand hygiene. So, they say in infection prevention territory, the mask is the first thing on and the last thing off, but it's preceded and followed by gelling in and gelling out. So the alcohol-based hand cleaners, keeping in mind that at some point after every several alcohol-based hand cleaning events, you do need to do the soaps and suds to get the debris and the film off your hands. So there you go. That's it's a very important question as we can contemplate how to go forward. And if you are tuning in from one of those 4 states, New York, California, Illinois, Massachusetts, in which your hospital or clinic space is considering a mask mandate, I encourage you to have a conversation with your infection prevention director, if it's hospital-based, or among your practice mates in the ambulatory setting, and just, I think, be very clear about benefits of wearing a mask all the time. Certainly, that is one way to try and avoid all possible infections in terms of risk to self, but also keep in mind that doing proper mask mandate with sick patients has been, and it continues to be proven to be, quite effective. One additional point, if you need further ammunition against mask mandates all the time, if you feel they're not appropriate for your practice setting, during the height of the surges during the pandemic, and here we're talking the initial variants, so alpha, beta, and delta especially, there were numerous reports and population-based studies of healthcare workers who were becoming infected despite the mask mandates in their, especially hospital setting. And the reasoning behind that was, as much as healthcare workers protected themselves in the healthcare setting, at some point while at home or going out for dinner or whatever social event, the masks came off, and or there was a breakdown in hand hygiene after taking off the mask to go to bed. And so healthcare workers were still getting infected, as do we, even with the flu and RSV and other things, despite wearing masks in a risk-based way or in a universal way. So it still comes down to being cautious in all elements of our life, not just the healthcare setting. Okay, my mini little soapbox there, we're getting off of it. Next question. Has JN.1 overtaken HV.1 as the leading COVID Omicron subvariant in the United States? Yes, it has. Last official data coming to us from the CDC, and this is based on reporting states around the country. It comes to us in a report on January 5th of 2024, and as of that time, the J.N.1 subvariant is accounting for 62% of all new cases in the United States. That is far exceeding HV1 and all the other subvariants of Omicron. Also, the JN1 is dominant in Europe and increasing numbers in Asia. So that would be, at least for the second week of January in 2024, most likely still our predominant strain. Ultimately, does it really matter? Probably not, because even the emerging subvariants, including JN1, there is still at least partial, if not good, efficacy against severe disease by the current booster vaccines applied through Pfizer, Moderna, and Novavax. So there's still a very good match with the spike protein construct of the new subvariants. And also the new subvariants, including JN1, continue to cause similar disease. No increase in virulence, no increase in mortality or morbidity over the preceding subvariants, even over the last year or so. What has changed again are continued accumulated mini mutations affecting many spots, but especially those of the spike protein, so that it binds more readily to its ACE2 receptor on especially respiratory epithelium, and therefore can create a higher viral load, making it potentially more contagious. If you think of it from the virus's perspective, this is all survival, right? I need not to, kill my human host because that stops my transmission, but but I do need to bind far more effectively to increase higher viral load and thus be able to continue to infect more cells and propagate myself further. So, not to anthropomorphize Mother Nature, but that's exactly what's happening. Survival benefit comes from exactly this pattern of mutation and survival. So, and that's what JN1 is doing. So, for right now, JN1 is our dear friend, and will continue to be so until the next subvariant, emerges, mutates, and then does its thing. Next question, and we're now turning to sort of RSV. Why do I think RSV cases peaked before the current COVID and flu cases have peaked this season, unlike last season when they all peaked at the same time? So, very important point, last season was a highly unusual, highly unexpected, although in retrospect completely expected, combination of all the respiratory viruses getting active all at the same time. And that in large part had to do with several things. First, a significant relaxation of isolation protocols in social settings, meaning the masks came off, and an increase in our pediatric patients, at least, returning to schools without protection, and social events and sporting events, and this and that and that and this. So it took, a good half year or so for all that exposure of children, especially, to their classmates, sports mates, teammates, dance mates, etc., to share that lovely little gift of any respiratory virus they happen to wish to share. But those numbers increased and peaked when it all sort of came together in a great big Armageddon of respiratory virus terribleness. And that'll happen at the same time, largely because we had an unherd immunity-protected population of kids who had been mostly isolated and just had lost that immunity, partial, to prior respiratory viruses. So that's factor two. So we came out from behind the masks, started to expose each other, and we have a population of susceptible children and adults, all of whom then shared the respiratory stuff all at the same time. So that was sort of a perfect storm of exposure factors to create that simultaneous onset, which, as we know and talked about in this podcast, was truly near catastrophic. This year is a far more typical year. Yay! So we started with RSV on the East Coast and Southeast, and thank you and sorry to those friends of ours on the podcast listening audience who are in those areas. So it started there, and it sort of moved in the general direction of Arizona, and so we got it 3 or 4 weeks later. And similarly, then the flu, which has a later onset typically. SARS coronavirus 2 has not yet completely settled into whatever its seasonal pattern is going to be, but like other upper respiratory viruses, it makes sense that it will also emerge in the colder months, which it has, and follow similar patterns. So we also know that influenza was a little bit later in onset, and so too with our current mini surge of SARS coronavirus 2, because up until recently, most parts of the country, which are usually far more wintry in their December months, were not, right? We had a major delay in onset of snow and wintry weather up until quite recently. So as those environmental factors increase nasal mucosa inflammation and that lovely nasal drip because you came in from the cold, then we can expect respiratory viruses to follow just epidemiologically. This year is so far a much more typical season, and I have a sense, and I would anticipate, that this is going to be typical for us going forward. So we can think of SARS coronavirus 2 as a similar timing of onset along with influenza, and that indeed is happening right now this month. But RSV and rhinovirus will always precede that by a certain amount of time. So there you go. And I think, again, we can see what will happen next year, but I have a sense that that's exactly what shall happen. Last question is, can I review the updated guidance for healthcare providers as we start to get increased supply of nirsevimab or Beyfortus? And assuming everybody is thinking, dreaming, tasting this in your sleep, because we've heard nothing but this is the monoclonal antibody product which has been created and approved for use in babies beginning from very early age. So all infants down to birth or 3 days of life up through 8 months, and then a secondary risk population who are in the older age up through like 18 months or so, or 19 months officially. So we know that this is quite effective. We know that this is an amazing product. We know that it was approved, and we know that there was no supplies left at all potentially for anybody. And fortunately, steps have been taken at the federal government level and the CDC and the FDA to redirect supplies from the manufacturers of nirsevimab to away from the southern hemisphere where they are not currently experiencing an RSV burst, and redirect those here to the northern hemisphere where we are. So, as the questioner is aware, we can anticipate increasing supplies, finally getting some of those orders filled that I'm sure everyone has placed for the last, 3 months since we had official approval, and we can start then to redistribute. So in anticipation of that, the AAP has released just sort of confirmation of how to prioritize this hopefully newly increased number of doses to our patients. And there really are no surprises here. So in a perfect world, we would all have as many doses, both 50 milligram and 100 milligram doses of nirsevimab, as our little hearts could desire, and we could just do it as per complete the normal recommendations. But, of course, we know that it's going to be a trickle of supply, which may be coordinated in some cases by state or local health departments, and or just by who got their orders in first and who has the best relationship with their pharmaceutical rep to get doses delivered. But in the setting of increasing supply, and I'm quoting directly from the AAP statement, we will continue, or we should administer at single dose, a 50 milligram dose of nirsevimab, to all of the babies aged less than 8 months. If they're full term and over a certain weight, then it's 100 milligrams, and also to all children from 8 through 19 months at increased risk, meaning those with typical risk factors, so chronic lung disease, former premature infant, certainly under 34 weeks of gestational age, congenital heart disease, immunodeficiency, etc. If we are still in an area of limited supply, then we're asked to prioritize first by high-risk conditions. So for the babies under 8 months, and then the secondary, or the second exposures for 8 through 19 months for the high-risk conditions. So again, severe chronic lung disease, active respiratory disease, immunodeficiency, congenital heart disease. And then we would prioritize by age. So going for the youngest infants first, so the ones from birth, basically, first week of life, up through 8 months of life. And we always prioritize youngest and highest risk conditions first. So those of you who may be working in or serving neonatal ICU, of course, your kind of patients who will be first prioritized, followed by the newborns in the newborn nursery, and keeping in mind that in the first couple days of life, the risk of exposure to RSV immediately postpartum is low. So one can wait and allow those patients to be, I'll use the term vaccinated, but it's passive immunity, in the primary care setting at that first follow-up visit after delivery, if there are supplies there. So at my local hospital, we have not yet seen the increase in supply coming through, and yet there are some community providers in my county who do have some doses. The large FQHC clinic setting has some, which is yay, and the local county health department has some as well. So we are prioritizing our limited number of doses for those infants who are currently still in the NICU and at risk. And then all others, the newborns who are going home, hoping and anticipating they can get theirs in the community. And that is hopefully going to be increasingly possible as these doses come through. So if you want more specific details, again, the prescribing information is available online. You can search certainly nirsevimab or go onto the AAP website. For those of us in Arizona, the Arizona AAP has access and links to that as well for specific dosing and recommendations. But basically prioritize high-risk conditions first, followed by age, youngest first, and then hopefully we'll be swimming in nirsevimab by the time the RSV is no longer all that ubiquitous. Fabulous. Okay, so that is it for this week's questions. Just a couple other notes of what is out there. We've talked, of course, about the respiratory viruses. We've seen a fairly significant increase in several disease processes, including pneumonia with complicated or loculated effusion following either RSV or influenza. The pneumonias have been caused, at least in my local practice area, by a smattering of group A streptococcus and streptococcus pneumoniae. Not surprising, though those would be the typical ones. The third organism to consider if you have a patient with pneumonia and a complicated effusion or even empyema should be Staph aureus. MSSA has been the most common, but there are some patients with community onset MRSA, MRSA. So these patients are typically coming in actually with a fairly subacute onset of illness. So starting with the classic upper respiratory, illness, which again, RSV, influenza, rhinovirus, etc. And the fevers then seem to resolve, and then they have onset of the fatigue, one-sided chest pain, maybe tachypnea, and the malaise, decreased appetite, anorexia, which comes along with the emerging occult bacterial infection. So if you should happen to have a patient like that present to you in your practice area, have a very low threshold to get the chest radiograph and look for the dense consolidated either pneumonia and or whited out lung with a major effusion. So that is one disease process we're seeing a lot of. We're also seeing a significant amount of retropharyngeal phlegmon, retropharyngeal cellulitis, retropharyngeal abscess, and also cervical lymphadenitis, most of which again is going to be bacterial following a viral inciting event. And so a lot of those patients are coming in through the emergency department, meaning that the EDs, of course, remain quite busy, but so too do our colleagues in ENT who are assessing these patients for either drainage and or airway management. That's the second category. And then third, and this continues to be seen nationally as well, we are still seeing a higher than expected number of invasive Group A streptococcus, or Streptococcus pyogenes, for those of you who like the formal name. And we're seeing everything from toxic shock-like syndromes to invasive musculoskeletal infections to abscesses to the aforementioned pneumonia, effusions, epidemas. So that is out there as well. And of course, along with that, increased numbers of scarlet fever. So the bacteria are out there along with the viruses, big surprise. And again, our colleagues in emergency medicine are keeping themselves quite busy, as would be expected. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 and many other infectious diseases in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, and as always, thanks for tuning in. Hope you are all staying healthy. Remember to wash those hands, and thank all of you for your service to children.